Thank you all so much for being here. My name is Naomi Inglar. I'm the Communications Coordinator for the Tulane Prevention Research Center, as well as the Tulane Center of Excellence in Maternal and Child Health. We're two of the co-sponsors for this series, the Fall 2017 Health, Racism, and Communication Seminar Series. We want to thank you guys so much for being here. We want to thank the student groups who, without them, we wouldn't be able to make this possible as well. So I'm going to read all of them. There's 4. We've got the Tulane Society of Young Black Public Health Professionals. We have the Tulane Society for Sexuality, Health, and Gender, Salud for Latin American Communities, as well as the Student Government Association for the Tulane School of Public Health and Tropical Medicine. And 2 of our student group leaders are going to introduce our speakers today. If you didn't sign in, please do. Please take an evaluation form. Those are important for us so that we know we're delivering the seminars that you want to hear and experience. So do please fill those out. And we will be recording this, the audio and the slides. So if you sign in and gave us your email address, we'll send you the recording. And I will let our student leaders do the introductions.
Hi, I'm Allie, and I'm with Tulane Society for Sexuality, Health, and Gender. And I will be introducing Earl Benjamin, who has been a public health practitioner for over 15 years. He has led the execution and development of national, regional, and statewide public health initiatives. Earl acquired his NMA ECT certification as a cultural competency trainer in 2008, and in 2015 he was distinguished as an American Psychological Association Health Equity Ambassador. He considers himself a health equity strategist and community health worker. Earl is a health science doctoral graduate of Nova Southeastern University College of Osteopathic Medicine and Health Sciences.
Yeah, okay, I'll do the next one. So hi everyone, I'm Kiara Cruz. I am the president of Salud, and I have the honor to welcome Michael Robinson. Michael Robinson has been a social services and public health practitioner for 18 plus years. He has provided services in a variety of capacities, including substance abuse counseling, youth counseling, behavioral interventions, trainer of trainers, public health education, infectious disease prevention and testing, tobacco education and prevention, program development and implementation, community mobilization, and grant writing. Michael is a proficient mental health practitioner, a sought-after motivational speaker, and highly skilled facilitator and trainer. Let's welcome Michael.
Good afternoon. Again, my name is Michael Robinson, and this is my partner, Earl Benjamin, partner and husband, Earl Benjamin. I just wanted to start off by humanizing this presentation a little bit by letting you know a little bit more about us. Earl and I, by next month, we will have been together for 15 years. We've been married for and we've been married for about a little over 2 years just now. And in that time, we've had the opportunity to live and grow through the experience, what we identify as the gay experience. So much of what we'll be talking about today is not only what we've learned academically and through other work experiences, but it also is very much a part of who we are and what we believe in and how we operate in society and how we look at politics and look at institutions, relationships. It really drives and motivates most of what we do with the work that we do with the BACH group. But not just with the BACH group, with our own personal lives, and it stretches out into our work professions. Our friends probably get annoyed by the fact that we'll always bring this up or find a way to bring up these really impactful subjects within just general everyday conversation, because for us, this is a part of our lives. This is real for us. So we hope that you enjoy the presentation today. We are going to ask that we got a lot of information to go through. We're going to ask that you hold questions
We have 12 slides.
to the end. But we will make a generous amount of time to answer questions and have discussion because we really want to hear back from you all as well and have a good conversation going. So without further ado, we're going to get started, and I'm just going to start.
So welcome, 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 and again, thank you to Tulane School of Public Health and the other programs for inviting us here today. As I stated, I'm Earl Nupsius Benjamin. I mostly go by Nupsius. And again, thank you guys for coming today. So a symptom of bigger issues, exploring Black, same-gender loving, trans, and queer health disparities. Now, when I initially sent this presentation to her, I just put LGBT. I want to take the time to clarify, one, what same-gender loving is, and two, why we're saying it, why we changed it to this. So I identify as, and my husband identify as same-gender loving individuals. That language comes from Dr. Cleo Manigo, in about the 90s, when there was a lot of empowerment movements going on, particularly inside the African American LGBT experience, and we wanted to reclaim and own what was ours. And so out of that movement was this language, same-gender loving, which is lesbian, gay, and bisexual. And so where you see me saying same-gender loving, that is lesbian, gay, bisexual, it's for African Americans. And so in a lot of the presentation that we're going to talk and cover today, you're going to see me say same-gender loving, trans, and queer. So that's why you don't necessarily see lesbian, gay, bisexual, and transgender. So we're catching it in same-gender loving.
And we may mention this again later on, but just so that everyone is clear, the terminology queer has had many sort of evolutions over the several decades, but it has really started to resurface again, even within the African American community, where it never really quite had a home, but it's surfacing more now because you have people who are gender non-conforming, people who don't want to subscribe to a certain particular label. So it's kind of more of an all-encompassing word that people can use to identify that I don't really want these other labels. I am just me. And so it can mean a number of different things for different people. So we just wanted to add that to them.
And before we go any further, I am a person that is grounded, very grounded in who I am as an African American. I'm grounded in the experience of my ancestors. And so when we created BACH, and BACH stands for the Behavior and Community Health Group. BACH also has a nonprofit attached to it, PROPS. PROPS stands for Capacity Building, Resources, and Opportunities for Populations. And so in creating BACH, I wanted to base the principles of BACH on something that was African focused. And I was looking for an Adinkra symbol. And many of these symbols are symbols that come from the west coast, Ivory Coast of Africa. And I found one that really spoke to what Michael and I had done in the past and what we were looking to do moving toward the future. And this one, Inframadan, which it really just means a house or vessel that can withstand the vicissitudes of life. And so the work that BACH does and PROP does is really about building people's capacity and self-efficacy and esteem to go through and overcome many of the societal issues that happen to them and many of the things that they go through. So that's what a lot of our work is grounded in. It's about building a capacity of people to withstand, go through, overcome, and be and become better. So after saying all that, let's go ahead and get started. So the objectives of today's session, list examples of health disparities that impact Black LGBT community, define social determinants of health, describe the social determinants of health that contribute to and or exacerbate health disparities in the Black LGBT community, and define the importance of communication to address health disparities and systematic oppression. So I want to start by what we will cover in the end. And so probably a few months ago, this book, the first book of its kind, came out and the editors are Dr. Folings and Dr. Lannister. Dr. Folings is a social worker, a licensed clinical social worker. I cannot remember what university she works out of in New York. And Dr. Lannister is a licensed clinical psychologist. And I can't remember his university either. But they were the editors of this lovely new book that has just come out. The title of the book is Black LGBT Health in the United States. Nothing like this, to my knowledge. This is the first time that something like this has ever been written that focuses on our health. Black LGBT individuals, same-gender loving individuals' health. I would encourage you guys that are interested in this subject to go and read the book. It's a fascinating read. But yeah, so in reading the book, I got 3 areas of takeaways that I wanted to start the session with, and I'm going to go through these at the end, but I wanted to make certain that you understood these takeaways. And so Dr. Lannister, in writing his portion of the book, he indicated that there were 3 areas that we needed to focus on that could help to improve health holistically for same-gender loving individuals, trans individuals, and queers. And that, queer individuals, I said queers, forgive me. Health policy, health research and dissemination, and healthcare service delivery. He had several examples of things that could be done, and I'm going to run through a few of them. So as it relates to health policy, he indicated that we needed to create a national pipeline education programs that target and recruit early on Black students in elementary to promote interest in healthcare and research. He also indicated under health policy that we develop more targeted grant scholarships and culturally matched mentoring programs for Black, same-gender loving, trans individuals. And 3, under health policy, he said, make more systematic efforts to recruit and hire and promote Black, same-gender loving, trans people on federal, state, and local government positions. As it relates to health research and dissemination, 3 more that I highlighted. There were several of them, but I took out the ones that I think that were most pertinent to the conversation that we're having today. So under health research and dissemination, make more systematic efforts to recruit. Again, some of these will bleed. Make more systematic efforts to recruit and hire, promote Black, same-gender loving, trans people in federal and state local government. Educate administrators and faculties on broad array of scholarly and non-scholarly research dissemination outlets and their importance to the community's work. And we're going to find out why this is important a little bit later. You're going to see throughout it why this is significant. And thirdly, as it relates to health research and dissemination, federal, state, and local educational accrediting agencies and foundations need to finance calls for proposals for preference on culturally specific research that utilize resilience. It's important that we sometimes, resilience has become a bad word for many because in New Orleans we kind of use it too much. We say this resilience. But one thing that we don't talk about enough inside the experience of African Americans or inside the experience of Black, same-gender loving individuals is those that were able to, despite what happened to them, despite the circumstances, there are some good things, positive things that are happening inside our experiences. And so one of the things that Dr. Lannister outlines inside this book is there's a need to discuss, to have a comprehensive picture of the health that exists inside our communities, the lives that exist inside our communities. The other day I was listening to Dr. Herman Teller, who used to be the researcher over the Jackson Heart study, and he's now at Morehouse. I can't remember which program he's over, but he also talked about this in a webinar that he did yesterday, that we don't talk about the successes, the good things, the good health outcomes that are happening inside the African American experience. Imagine what it must feel like as an African American to be always bombarded with, you got this, you got high blood pressure, you got high pregnancy, you don't have jobs, but that's not the total and complete picture. So I got off on a tangent on that, but that really spoke to me under health research and dissemination. There's a need for us to not only focus on those things that are negative. We also need to highlight those successes that we're having inside these populations.
Let me also add to that about health research and dissemination. One thing that you will, and we may mention it more than one time throughout this presentation, but it's important to note that almost every study, article, information that you can get your hands on as it relates to the same gender loving experience specifically, will say that this research is limited based on the fact that there's no data out there for it to piggyback off on or to refer to. There's just not enough data for the entire LGBT community in general, not just African American, but then even when you drill down to the African American community, you're talking about very, very, very little data, which is why Earl was very excited to find this book, which is the first of its kind, as he mentioned, because this is, for us, maybe the beginnings of a Bible for us, and so in a way, so that we have some kind of research that we can readily come to. But just note that as we go through many of the different various health disparities that we're talking about, the research is oftentimes limited by the fact that there's not a lot out there to begin with in the first place. And I think that that's a very important point that we should mention when it talks about health research and dissemination.
And so thank God for Obama. We'll get to that later, but I want to say that in this part right here. And so the last one, I just pulled one of the recommendations that he highlighted in it. And so as it relates to healthcare service delivery, provide funding for Black, same-gender loving health providers to provide community-centered health care. Going beyond just handing someone a pill, going beyond just telling someone you need to get a pap smear, going beyond telling someone you need to use a condom, going inside the community and finding out what is really the issue. What is going on? Because as we talk today, what we're going to find out is we've spent a considerable amount of time talking about behaviors and not enough time talking about the social conditions in which people live in. Let me repeat that. We spend a considerable amount of time talking about behaviors and not enough time talking about the social conditions in which people live in. Yes, behaviors are important. Yes, we can find some nuggets there to do some interventions with. But as it relates to the Black, same-gender loving experience, when we look at our HIV and AIDS rates, we've been telling people to use condoms for a long time. We've been telling, and now and that's good. And now we're telling people to use PrEP. And despite all of that, rates of HIV inside this population will likely increase, are going to continue to increase, despite the successes that have been had in their counterparts. So those are, and I'm going to reiterate those again, and I will also write, because they're not in the presentation, but I'll send it to Naomi so that she can share what we have written down in our notes regarding that. So, the title of our session, Symptom of Bigger Issues. So the symptom for me, as an African American that is same-gender loving, is HIV, a high burden of HIV. So each of these black dots represents a symptom of something. High number of HIV. In the United States, smoking rates have dropped significantly low. But inside the LGBT community and the African American LGBT community, smoking rates are at 30%. We only have 117,000 LGBT adults in this state, and 30% of them are smoking. These black dots represent obesity. We have a number of lesbian, whether they be not African American or African Americans, are obese. We have a number of lesbian and trans men who have high risk of developing certain cancers because they're not getting screening. We have trans women who are experiencing a significant amount of violence. And so for me, all of these health disparities, all of these health inequities, they're happening inside a system, and we only want to focus on, let's focus on this thing right here. Let's focus on HIV. That'll fix something. and it's not really doing it. Let's just focus on, we're not even going to talk about the cancer rates for trans men or lesbians, but we're just going to focus on HIV. We do ourselves a disservice when we only talk about certain things that we know are happening inside a very small population, when it's evident that many of these things that are happening to them as a result of the social conditions in which they live. So I took those symptoms and I just placed them inside this social ecological model. I'm sure most of you know what this model is. You know that it has the individual level, it has the interpersonal level, organizational level, community level, and public policy level. Before I talk any further about this, I want to highlight something that Dr. Lannister said inside his book. He indicated that he writes that the multi-level marginalization has contributed to some of Black, same-gender loving, trans, and queer people adopting a view of themselves as a problem. Earlier I talked about how oftentimes when we talk about public health, we see a number of negative things when it comes to the Black experience. And so imagine what that must feel like being an LGBT individual or same-gender loving individual. Not only are you Black, but you're experiencing some of these other things. That's a lot. And so we write, the multi-level marginalization has contributed to some Black, same-gender loving, trans people adopting a view of themselves as a problem. This conceptual incarceration, which is the internalization of false ideologies that do not affirm one's beingness. Our wholeness results in learned helplessness and personal reenactment of oppressive trauma. It contributes to negative self-views, physical and mental disparities, i.e. depression, suicide, and cancer. So at every level of the sociological model framework, this individual, LGBT Black individuals, and even our LGBT counterparts are experiencing some sort of trauma that says you are, one, not supposed to be here, you are insignificant, you are not important. So at the public policy level, we used to have laws, and in some areas we still might have laws, where gay men could go to jail for having sex in their own house. Is that still on books?
Yeah, so, I mean, just to expound upon it a little bit, where you're going with is just that there are certainly even laws here in Louisiana that allow you to legally discriminate against people who are same-gender loving, LGBT, transgendered, or queer. There are certain laws that were in Crime Against Nature. There are still laws on the books that says that you can't, certain types of intercourse is considered sodomy and that sort of thing. So, while those things may not always be enforced in our everyday lives, rest assured that there are some individuals who are trans individuals, for example, may be subjugated to these outdated type of laws. There are individuals who are in Louisiana who have suffered under the fact that our laws are outdated. The policies are outdated and do not keep up with the science that we know about, say, for example, HIV. So you may have heard that there are people who have been incarcerated because they've bitten someone and that someone said that person had HIV. We know now that that's not a way that you would transmit HIV, but our laws have not caught up with that level of knowledge that we have now. So some people still fall prey to certain policies such as that. Yeah.
So at the policy level, the policy can set culture, and culture can also set policy. So as a Black LGBT individual living in this world, we are aware of that there are policies in place that indicate that our lives are insignificant. We are then aware that as a result of those policies, or as a result of the culture that we live in on the community level, that there are certain attitudes that come out as a result of that. There are certain experiences that people will have with community institutions and organizations that indicate that you are less than, you are insignificant, going all the way down to interpersonal family. I mean, all of this compacts and compounds and exaggerates, not exaggerates, but exacerbates what an individual, a black LGBT individual, must feel like to live in their body, in their beingness. So my point in sharing this is that we aren't necessarily preparing people to live in their wholeness. When we have policies, when we have communities, when we have organizations, when we have interpersonal relationships, and when we have self-hate on the individual level that say, I am insignificant, I am not important, and as a result of that, you expect people to go out here and be happy, well, and be productive. It's not going to happen. And so for me, we're laying the groundwork to understand why HIV is not the real issue for me when it comes to what is happening with gay men. It's not the issue, it's the environment, it's the social conditions that is the issue. So, social determinants of health. So, we know what social determinants of health are. Social determinants of health are those social and economic factors that contribute to negative health outcomes. That's it. Anything that exists inside a community in an environment that could cause something negative or positive to happen to someone's health. But when you go and you look at a specific definition for it, one, you find a wide variety of them. And so you don't really get a clear picture on what they are. And so I wanted to just illustrate that by just putting up what I found when I looked for social determinants of health. Now there are key themes that we see throughout this. We see education, we see housing, we see community, we see healthcare, we see occupation, income, gender, economic factors, I believe, is that what that is? And I had to hunt. We see food, schools, but I had to hunt to find the social determinant of racism. There was only one in my search where racism was clearly identified as a social determinant. I want to give you 30 seconds to someone to share with me why is that. Why do you think that there only was one illustration, infographic, that illustrated racism as a social determinant? Yes, ma'am?
Probably because it's difficult to define and measure.
It's difficult to define and measure, yes. And you know what, that's fascinating because when it's happening to me, it's very easy to define and measure it.
I've been exposed to a framework that argues that the social determinants don't get at the root causes, and racism is a root cause,
Yes.
among other forms
True,
of
true,
oppression.
true.
So that's my answer to why you find it, because it's not a social determinant.
True.
It's a root cause.
I also think, to add to that, I also think that, you guys have heard of the in and out group theories. And so, for the most part inside the United States, are African Americans the in group? They're the out group. And so, most of the individuals putting most of these things together, they're the in group. There are not enough of us from the out group helping to inform these things. And so, for me, that's a lesson learned that I think gets at the fourth objective. Let me make sure I reiterate what the fourth objective was we're going to do in today's session is define the importance of communication to address health disparities and systematic oppression. So we need to be aware, for those of us that are in the out group, the in group, that we have to be thinking about what's going on in the out group, who's not sitting at the table, because their ideas aren't making it to the forefront. Now we're going to see later how this affects some of what I think is happening when it comes to health disparities for LGBT individuals, particularly black ones. So it took me a hard time to identify an infographic that illustrated specifically racism as a social determinant. So two very important points that I think are pertinent to this conversation around social determinants. And the first one is the distribution of social determinants are shaped by public policy. The distribution of social determinants are shaped by public policies that reflect the influence of prevailing political ideologies of those governing a jurisdiction. So some of the health disparities that we see, they're happening because as a result of the public policies that we have in place. So that
Or
means,
lack thereof.
or lack thereof. But for the most part, they're happening because policies are in place that allow that to happen. We have to have discussions about that. The second most important point is this unequal distribution of health damaging experiences is not in any sense a natural phenomenon. We can't just walk around and say, oh, well, that's just the way it is. We have to understand that there are certain factors that are existing inside our social condition that are contributing to these health disparities that we see. So when we see these large amounts of, well, one, we don't have a lot of data for LGBT individuals overall. When we see Latino men and black men HIV rates be as alarming as they are, and we've been hearing this for a number of years, at some point, we have to look at the policies that are in place. When we know that when we go out and we do screenings that lesbians and trans men are not getting screened, and that's putting them at risk to develop later stages of cancer, we know this, but we haven't looked at the policies or examined the policies to see how we can stop these things from happening. So that we have to be very intentional.
Yeah, one example, how many of you are aware that even to this day that gay men cannot give blood? Yeah. So, and I'm glad that quite a few of you are aware of that. And that's based on a policy that was created some years ago, a long time ago, when it was more believed that, just gay men were the harbingers of disease, if you will, specifically in this case, HIV. So there again, we have policies that are damaging, and as it said in the last slide about what was the specific wording I think he used? I know he said something about it was the damaging effects of some of these the messages that go out, because and for me, I'm a social worker, so for me, a lot of this stuff, I have to have a very humanistic side to it, and I guess we'll get into some of that part of it. For me, I think the way I would help explain some of this is to share the realness of what we're talking about, because this is all very academic and it sounds great, right? But what are we really talking about here? What we're talking about is when I started going out to the club as a young teenage person who shouldn't have been out at a gay bar when I was that age, right? But where else in that time was a young black gay boy going to find acceptance, camaraderie, fellowship, all of these things that some of this stuff is touching on, but policy doesn't really get to some of that, really. Okay? So when I go into this club, I'm like, I'm home. These are my people. Where have they been? But at the same time, I'm exposed to, because at that time, their laws were not in place, you could smoke in public facilities, including clubs. So here I am with my little 16-year-old lungs in the club, just dancing and inhaling all kind of toxic fumes, right? So this gets to the point of what he's saying about sometimes it's not necessarily our behaviors. Our behaviors, for those of you who are social workers, because I know y'all in here, right? We know that our behaviors play a critical role in how we move forward and matriculate through life. But using that example, I was exposed to an element of life that I could have easily started emulating myself. The fact that I was inhaling toxic fumes. Here again is my environment actually affecting my health. Not so much, my behavior getting myself there, that was a part of it. But I wasn't electing to smoke. I wasn't necessarily electing to see that imagery so that it actually started to wear down me mentally to where somebody could maybe convince me to do so. You see what I'm saying here, how all of these things are connected together. So but the policy is now that you cannot smoke in these public facilities. So young people who might have been in my situation and their current today, they may not have that type of environment which would maybe increase the likelihood of them potentially becoming smokers. So it doesn't completely eliminate it just because of the policy, but imagine how it increases the likelihood that we will have safer people as they get older. Because now, seeing somebody who may be in the gay world, there are celebrities. You know, you got people who are drag queens, many of you might remember, and to us, they're our celebrities. And so if the drag queen who is known among all of these young people and idolized, and if she, what do you think some of them will do? So again, there's the environment, there's the influence, but yes, behaviors play a part in it, but we cannot forget how our environments really have a lot to do with how we might feel about ourselves, how we feel about our communities, and that influences how our behavior is.
So I'm going to rush through the some of the remaining slides because I know some of you will be leaving at 12:50. But I was researching social determinants, and I found a lot of them, as I showed you earlier, that were very academic in nature. They were very specific and abstract, but I wanted to find social determinants that African Americans themselves, via focus groups, identified those determinants that existed inside their community that were keeping them from being the best that they could be. And this is, I've located Scott and Wilson's study from 2011, and these are some of the social determinants that they identified. Lack of engagement with personal, and it goes in order to the social ecological model. So at the personal level, a lack of engagement with personal health and health promotion. For me, what I see happening in the Black community and also in the Black LGBT community is I can't prioritize health because I have all these other things going on. I can't, when I started working and making an income, I made a point to go to the gym, to continue to go to the gym. And I remember this one day, I realized that was such a luxury. Just getting up out of my office, I might leave it 2 o'clock and go to the gym. But I mean, that's a luxury. And so for many individuals, particularly Black or Black, same-gender loving, trans, queer people, that's not necessarily a luxury because I'm dealing with all these other social stressors. And so a lack of engagement with personal health and health promotion. Participation in primary health activities and education is minimal, even when offered. Again, I think it speaks to, it's not a priority. It can't be a priority. I don't want anyone walking away from here thinking, and if you do, it's just because you decide to think that way. Oh, see, it's them. That's just how they are. That's just how they are. No, that's a human being just like everyone else. And it's likely because of the social conditions in which they live. We have to get away from this idea, or we have to be comprehensive in expanding our understanding that it's not just about behavior, it's about environment and social conditions as well. Number 3, a lack of social capital. There's a disconnect inside the community between community organizations, entities, and efforts. The community built environment was an area of concern as it lacked opportunities for physical activity and access to healthy foods. And then these focus groups were done in the South. The local job market was abysmal for many African. That was one of the factors, social determinants that was identified, the job market. Racism, cronyism, nepotism, favoring whites. Local policies and funding allocations favor whites. School system tracking policies were perceived as discouraging African Americans from university education. High rates of poverty, racism emerged as a potential social determinant, and persistent stress. Persistent stress. What does stress do to human beings? What can it cause? Trauma. Can it cause cancer? It might cause you to start using drugs. It can cause a number of things, but stress was one of the things that was identified and it was distinctly identified as being related to poverty and racism. And so the thing I like about these social determinants, it came from the mouths of the individuals that attended the focus groups or that were involved in those community activities. And so on that lays the foundation because those were African Americans. So when we look at black, same-gender loving, trans individuals, these are the bigger issues. These homophobia, stigma, racism, social economic status, those are the bigger issues. Those are the issues that are contributing to the cancer rates that we're seeing, the HIV rates that we're seeing, the violence that we're seeing committed to individuals. These are the major issues, social determinants of health, that are the issues. So when examining homophobia, if you live in a society where 55% of Americans believe that homosexuality is wrong, and we know that LGBT individuals are not in the in group, when laws get made, laws are going to be based on those values, attitudes, and beliefs, those negative attitudes, values, and beliefs that are had towards us. That's going to affect us. When we also have to deal with internal homophobia. When I was talking to my husband last night, and I was going through this, he's like, "Oh, you're so stiff. I need you to loosen up. I need you to share a story. And I need you to do something." And I said, okay. So this popped into my head the other day because I was talking about someone, and we were talking about, you never see straight people say, "Oh, I don't discuss sexual orientation." Have you ever heard a straight person say that? I find it fascinating when I come across gay people who say, "Oh no, I don't. Oh, and it's not because I'm ashamed of who I am. It's just that I don't discuss that." That's a part of the social conditioning that has affected you, that makes you think that something is wrong with you. Are you following me? We don't have, the in-group does not have to deal with that. But gay people, many gay people, still to this day, deal with that stress, that stigma of homophobia, that internal homophobia. And we also see it in the inadequate responses to funding health initiatives that are health areas that are affected by us. When we look at racism, race-based mistreatment is prevalent in the United States. We see a tremendous amount of propaganda, negative propaganda against African Americans. Do we not? Am I making it up, or do we not? It's as if, because I find it fascinating when we turn on the TV and someone has the audacity to say that Black Lives Matter is a hate group, and someone gives them a platform to say that. That's the environment that's why this is a social determinant. Racism is a social determinant because it affects the fabric of everything that we do. It affects all of the existence, our LGBT existence inside the United States. And lastly, social economic status. Blacks are nearly 3 times as likely to live in poverty as whites. Black MSMs have higher odds of not completing high school, have low income, and have, compared to the white counterparts, 2.2 times likely to be incarcerated. LGBT individuals overall are more likely to live in poverty. And as a result of many of these conditions of oppression, individuals, there's an increased amount of depression and anxiety. We see a tremendous amount of smoking inside the LGBT experience, and we believe, research is indicating that this is due to the life stressors that are happening. We see, I just came across some data that indicates that gay white men inside Louisiana, smoking rates are probably 31%. That's significantly high. It's stated earlier that we have about only 117,000 gay people inside the state. And so to have a population so small And then inside that population to have that many individuals smoking, that's a huge disparity. So for us, the issues, the symptom of bigger issues are racism, homophobia, and social economic status.
So, to just dive more into the various different types of health disparities that are out there that are affected by not just the the same gender loving community, but all African Americans as well. Here you'll see on the slide a number of those different health disparities. Many of you will be familiar with them, have probably heard various statistics through your lives that relate to various communities when it comes to this. So Earl mentioned earlier, if we just start with obesity, for example, again, and I have to preference a lot of what we were able to find, there's not enough comprehensive data to really link some things together, but you can infer quite a bit. So one thing that we do know when it comes to obesity rates, that within lesbian women and trans men, for example, they do report less eating of vegetables. They identify with overweight status.
Right?
Millennia.
Okay.
Yeah, and but also it's cited that they may have particularly be vulnerable to poorer health outcomes given the additive impact of multiple social stressors tied to their gender, race, ethnicity, and sexual orientation, as well as unique forms of oppression. So what we're saying here is that lesbian women, because of stigma and discrimination, because of race and all these, that adds to the fact that actually it could increase the likelihood that somebody would be obese because of these things. Of course, behaviors play into this as well, because again, they reported eating less vegetables and what have you. So there is a connection or a dot right there. We've mentioned HIV on a number of occasions here. I mean, I have, we are over 30 years into this HIV epidemic. And one thing that we do know after a lot of research, although African American men may carry the majority of the disease burden when it comes to new infections, we have learned, though, that in comparison to the white community, African Americans are not doing anything any different as far as protecting themselves. In other words, they're reporting that they're using condoms, reducing number of partners. They're doing safer sex activities, okay? In fact, studies will reveal that African Americans may be using more protective factors to keep them from getting infected with HIV. However, I can say even here in Louisiana, over the past 10 years, the proportion of new diagnoses among gay and bisexual men has increased from 45% in 2006 to 61% in 2015. Obviously, something is not, it's not just about behaviors. There's some more factors that are going in here. I can keep going on, I want, but there are several other statistics here that basically show you even within black individuals. Well, 2015, 68% were black, 24% were white. So again, you're seeing the numbers increasing among blacks, but the research doesn't bear out that that they're participating in behaviors that would be indicative of them becoming more infected. So it has to be something else. What is it? It's some of these other things that we're talking about. Cancers. We know within cancer, and there's probably a number of different suggestive research. One that I can think of, because I've been, again, I mentioned at the beginning of this is a lot of what we're talking about. This is my life, right? So I remember I've worked in STDs for a number of years, and I've read many papers and statistical data that would suggest that gay and bisexual men who engage in anal sex have a obviously higher chance of obtaining sexually transmitted diseases such as herpes or genital warts. We know from the research that herpes and genital warts can cause cancers within women. We also know that gay men have a disproportionately higher rate of anal cancers. Come on now. Y'all coming with me now? So if you make the inference, you know, there's not enough research out there for us to know that herpes would cause anal cancer. But what I'm suggesting is that the inference is there. More research needs to be done to make the connection clear. But again, that's just one example of how cancers could be affecting the same-gender loving community, the larger LGBT community, but we don't have the research to back it up. Violence. We could go on all day long with how violence is specific to the same-gender loving community. Many of you have heard about the violence that happens against transgender individuals, even here in this city. It's been all over Facebook and what have you. And that's simply for people just being who they are. No, it's no wonder that somebody would be walking around thinking, is something wrong with me? That people have issues with me for just being who I am, just for being trans, just for being gay, just for living in this particular neighborhood. And so all of those things are external factors, right? Part of the environment that would lead one to maybe make behavioral choices that could not be as healthy for them, right? Sometimes we're ignorant of those things as well too, and that's why we also might be why we engage. But an ignorance of something is also a lack of the environment conducive for you to know that information, right? So again, it still always goes back to, we've mentioned smoking rates on a number of occasions, so I won't spend, to me, you can't spend enough time on depression because we all dealing with that. It doesn't matter who you are. All of us got some level of mental health issues that we're dealing with, right? But if you're really listening to what we're talking about today, you're talking about the black experience right here. And then I'm black and I'm gay. Oh my goodness, what if I had something else? What if I was Jewish? You know, I mean, but just think about what I'm saying here, because when you add on all of those things that other people, external factors may have issues with, they may create policies or the lack thereof. They may have constraints within your provider that don't allow for you to feel comfortable in that environment. So maybe I go into a clinic and I'm a black gay man, but I don't see anybody in that clinic that looks like me. I don't see any imagery. I don't see no brochures. Anything that says I'm welcome here. So it sends a very subtle message, not an overt message, that maybe you're not as worthy. Okay? And then finally, suicide. I could go on and on, especially when our youth, the National Youth Behavioral Survey, the one that we're not allowed to participate in Louisiana. Yeah, that one says that 10% of our young people were threatened or injured with a weapon on school property. 34% were bullied on school property. 28% were bullied electronically. 23% of gay and lesbian students who had dated or went out with someone during the 12 months before they surveyed had experienced sexual dating violence. And it just goes on. So here are just a few examples of the things the myriad of issues that the community is dealing with, but exacerbated by all of these other social determinants.
So, don't believe the hype. I think we beat this horse to death in this session. Behavioral choices are heavily constructed by a person's environment, i.e. social conditions, and behavioral risk factors account for a relatively small proportion of variation in the incidence and death from various diseases. Moving 2017. Racial disparities be not due to risk behaviors. Racial disparities not due to risk behaviors. That's something that Williams said in 2013. And the last one I want to leave you with, as a social worker or public health professionals or practitioners, we need to focus more on, or additionally, on the social determinants of health and or the conditions in which people live, not just behaviors. We need to have a holistic response and not a fragmented response to the health disparities that we see happening inside our experience. That's why there's a need, as it relates to Black, same-gender loving individuals, for when healthcare providers are operating, for them to go inside the community, see what's going on inside the community, and play a part in rectifying some of the issues that we see inside the community. We can no longer do business as usual and just giving people pills and telling people to use condoms. We have to go and identify what's going on inside trans men, what's going on inside Black lesbians, and even our LGBT counterparts, because they're facing some of these same issues. So why is this important? It's important to reduce, because it will help reductions in disease transmission and progression. It will help to increase mental and physical well-being, reduce healthcare costs, and increase longevity. You know, sometimes when I get up and I'm speaking, I get a little bit nervous, and that happens. And so that's why we believe the symptom of the bigger issues, the issues are racism, the issues are homophobia and stigma, the issues are poverty. Those are the issues that are contributing to the health disparities that we see happening inside the African American LGBT same-gender loving experience. So before I go to questions, so at BACH CROP, and as I stated earlier, CROP stands for Capacity Building Resources for population, in particular vulnerable populations. We go inside the community and we assess what is really needed to help address and empower individuals. And so a few months ago, my husband and I started convening meetings inside the New Orleans area to see what could be done to help empower, educate, and inform Black, same-gender loving individuals, trans individuals, or queer individuals to start moving us in a direction of empowerment inside the city. And so when convening with community partners, we came up with the Black Pride Education and Empowerment Talks. These talks are more or less a TED Talk that focus on discussing the issues affecting Black, same-gender loving, trans, and queer individuals. It will happen on November the 25th during Bayou Classic. That is also Black Pride, New Orleans Black Pride Festival weekend. And so we want to take advantage of both of those events. And it's an empowerment event. And we just confirmed today that we were able to get Big Frida to also be in attendance. And that's very exciting. But what's also very exciting is there will be one, the speakers is here sitting in the classroom today. Dr. Francois, who will also be speaking at the talks as an ally, talking about trauma. But the other one that I'm also excited about is Dr. Lannister will be coming down and talking about some of the research inside his book. This is an event for Black LGBTQ individuals and their stakeholders, and so you guys are welcome to attend. Please get the word out there. If you want to see more information about it, please go to www.thebachgroup.org. That's DTHEBACH group.org. Thank you, guys. All right, do we have any questions?
You should, if you're interested in attending this, you should go online to register for it. Registering only means that we will reserve lunch for you.
Yes.
I mean, you can just show up if you want to, but you may not get lunch. Yes, are there any questions, comments, or just discussion pieces? Yeah. Yes. It's going to be a part of the slides. When they send them out to everyone, we'll have that. Yes.
Just the departments, I guess, but one of the social determinants of the LGBT community talks about a lot is homelessness, and you didn't mention it at all. I was wondering if that's not something that the same-gender loving community.
Yes, it is. I didn't catch it.
Homelessness. We didn't talk about homelessness.
Yeah, we didn't really mention. I think it was in our notes. I never really saw it in the notes, but I think we might have glossed over that. But yes, especially here in New Orleans, especially, you know, we know that we have a huge youth homelessness population, and then gay and lesbian youth suffer even more so under that issue because oftentimes, as you can imagine, there may be displaced from their homes because their parents might put them out, or their communities might be shunning them. You know, some communities where you grow up, you know, the people in your neighborhood may be so relentless with it that you find yourself, oh, I'm going to go stay with my grandmother or my cousin or something like that. That oftentimes can happen in black communities and what have you. So yeah, it's a huge problem. We didn't address it nearly as enough, or not maybe some of the other issues that we deal with all the time. But thank you for bringing it up, because we know that's an issue that we need to be addressing as well.
And it is an issue that does happen to the same gender loving community. They have a phrase called floor kids. I think what happens is there are oftentimes situations where, yes, they're homelessness, but they may not be living on the street like their white counterparts are, and they go live in homes they develop gay homes, and so they call them floor.
Well, that might be a nice term. The actual term that a lot of them use are couch sissies or couch queens.
So, yeah.
Because they're basically sleeping on your couch.
Yeah.
And by our definitions, and since you brought that up, I think it's a great point to bring up. Our definitions of homelessness needs to change as well, because if you are under someone's roof, they don't consider that to be homeless. But you're just sleeping on someone's couch because they're allowing you. The next day, they could say that you have to go or something like that. So technically, you really are homeless, but our definitions don't allow for us to intercede and help individuals that need that, because our definition is too limited in what. But again, it's specific to LGBT youth, because that's oftentimes what we do. If mom puts you out of the house, yo, you're not going to come in here with that gay stuff, then I'm going to go stay with my good friend and maybe their parents who are more accepting. So now I'm homeless. But I got a roof over my head, so when I try to go get services, they're definitely, oh, well, you're not homeless by then. Call us when you slept on the street for a night. That's a problem, right? Okay.
So I found through my research that the black community is more homophobic than a lot of other communities. Do you know what social conditions might be, or cultural things that might, and how you address that?
I think part of that happens as a result of religion. I think African Americans are highly religious individuals, and so I think a considerable portion of that homophobia comes from religious beliefs. Being colonized, and so I think a significant portion of that just comes from religion.
Yeah, I would say that I would agree with that statement in a very general sense, of course. That you would probably find many African American gay and lesbian individuals who would agree with that statement, that there's a lot of homophobia within our own community. Another thing that we didn't mention, but I feel like it bears mentioning since you brought that up, people don't think about within the gay community there's a lot of racism as well, so just, we kind of tend, you see these wonderful pictures of all of us hanging out together out on Bourbon Street, all black and white Asian together, and we got rainbow flags, and we look like everything is wonderful amongst us all. And for many of us, it is real.
That's
a real thing.
Not many, a few.
But, okay. But the point is that we all recognize as well that there is a lot of racism that happens with even a marginalized group. So within the larger gay community, there's just marginalization. Within the black gay community, there's additional marginalization. So again, you see where we're going with this? I mean, what is a person to do when you're on the outside of the outside group? Yeah.
Yes, ma'am.
It's also suggested that it's hard to measure or quantify racism as a determinant of health, and I guess I'd argue that it's not hard if we being white people just don't want to.
Yes.
But I was wondering if you guys are aware of anywhere, like centers or universities that are doing work to quantify and measure racism as a determinant, I guess.
Who is the new director of, or the associate director of the American Public Health Association. Is she? Sam, what's her name? Oh well, last year. Well, she was.
Yeah, she was last year, but she just got a new guy. Just got
Okay.
elected.
I think she. I mean, what's her name again? I can't remember. Okay. I think Kamara Jones. I think she has done some work in that area, and I think what she has found, if I'm remembering correctly, because I believe Dr. Francois, you shared it last year at in service we had. She also looked at it from the perspective of how racism damages and affects white people negatively too. And so please look at her research. She's written a tremendous amount about it, and so that may be a place to start.
And there is, and I apologize, maybe if we can put it in the references later on, but there is a documentary the documentary is based off of research that was done, and I want to say this was maybe done in the 90s. And again, I'll do my best to try to locate that documentary, but it does try to quantify racism in the way of health. Like one of the things that I found really intriguing about this study was that they tracked African women from Africa who had come to the United States, who before they came to the United States, their numbers as far as their rates of heart, blood pressure and glucose screenings and all those things were normal or within acceptable ranges. After one generation of living here, their numbers were that of African Americans who live here. So that comparison right there already tells you that there is something in the dynamic of even, because of course they accounted for racism to some degree, so there's something within that dynamic of racism that actually causes additional stretches that affects health. There are studies or articles that are being doing exactly what you're saying, but you're right, there's not a lot out there. Yes, ma'am.
I think that the change in diet can affect health too,
Yes.
How does the outcome get to be
Repeat what she said.
She indicated that the diet change was probably as a result. The diet change was probably what contributed to that as well. And then what was your other question?
How does the outcome get to be income? How do you get into the outcome? What's the bet about that?
That's another session.
It is another session, but I mean to kind of answer it in a simplistic way, and it's not a simple problem, is in my opinion, you would have to tackle the issues of institutionalized racism. You'd have to start there. You'd have to look at because here's the thing. Racism in and of itself, individualized racism. Now, if I do something to Dodie that was discriminatory and what have you, now, yeah, that's racism, but I work for this institution and it allowed me to discriminate against her. That's where the real problem is, because we can't really police people's individual attitudes, behaviors, and that sort of way. We can police behaviors, but we can't really police those things or really even put policies on it, so to speak, on an individual. But we can start to look at our institutions, criminal justice, education, all these different institutions, and say, how does this institution institutionally marginalize this group of people over here? And that marginalization might be simply from the lack of acknowledgement that this group needs this. Does that make sense?
So I was just in a meeting where they talked about the importance of, to counter institutionalized racism, of having people in leadership positions who have the lived experience. So if you're an LGBT group, are the people in charge living that experience? And I think, Tulane University is a good example of the upper echelons of our university are not diverse. As much as they talk about diversity within the student body, that has changed. But if you look at the upper echelons, we're not walking the walk. And so the more that organizations, especially people who are trying to serve a community,
if they actually have people employed who have the lived experience, then that can bring it in.
Yeah,
Yeah.
it certainly make a huge
That's a
difference.
yeah. That's a perfect. I mean, that's what you find in most situations across the United States, even particularly here in New Orleans and in Louisiana. You have individuals at the top that do not really represent the differentness of everyone else inside the community, and so that is a real. I mean, that's a real issue, and I encourage institutions to deal with that, see it for what it is, and do something about it.
Yeah.
For the most part, I don't think people are necessarily trying to be bad. People hire who they feel comfortable with.
Yeah.
People, and that's but we have to call that what it is too. I mean, it is about being comfort, but it's also about being comfort around individuals that look like you, sound like you, and so yeah.
Yeah, let's think about and I'll get to you in just a second, but let's think about the debate within technology, right, that's happening right now. So women are considered the out group right now, right? If you look at Silicon Valley and they do the numbers and they say it's only like 30%, something like women who are represented within that industry, and they wanted to change that. So again, this is the out group. So something institutionally needs to change about that industry. And that may go all the way from how we're recruiting people even in high school or even in elementary school to say that, hey, here's a field that women should be, looking at as a potential area of income. But when we have societal norms and institutions that say boys do this and girls do that, then that's when we start to find ourselves in trouble, and we're starting to pigeonhole people into saying this is what this group is supposed to do and this is what this group is supposed to do. I'm sorry, yes.
I was going to say implicit bias plays a big role, because I think in terms of like the outputs and influence and stuff like that, I think it's just starting with the conversation. So we are privileged because we are in this institution, we are getting our education or we're in the field. So like having these conversations where we work, because if we don't have people that represent us at the table, then the people that are working there or the people that know people having these conversations and opening the dialogue and talking about those things. And also like I feel that trainings need to be done, because policies are good, but they're not good if they can't be enforced or implemented, right? So we can have a policy that says, let's do this, let's have a affirmative action, let's do this. But if people are not really following with the policy, then it's like you're just enforcing something because people are not following. So I think it's really getting into just having these conversations and have people check themselves and check the people.
Yeah.
Because I think that people don't know as well that, they haven't lived the experience or they never met someone that they can speak to and learn from it. But having these, being uncomfortable is what I'm trying to say.
Yeah.
The more we are more uncomfortable, the more we learn. So I think just putting ourselves as like individuals in uncomfortable situations where we don't know and we don't feel comfortable, we'll learn more.
Yeah. The problem is that people feel uncomfortable with being uncomfortable though.
Yeah.
Yeah. I thought I saw a hand up here.
We're sort of piggyback off that because policy does help kind of shift social norms, right? However, we are all on the same page basically. So how do we get our counterparts in here and really get comfortable? To me, I'm all about creating vulnerability because people embrace that. But I constantly feel like there needs this willingness to weaken it. So
Yeah.
this other extreme, and I don't know if we wake up on them. How do they get involved? Or how do we get them involved? How do we shift that social norm through communication, not just policy?
Yeah, so policy gets you some part of it, but how do we engage those that may not agree with what we're saying here today? Because as you're saying, we're kind of preaching to the choir here. And I'm sure Earl may have a comment, but one of the first things that I would say is to create safe spaces for people to have dialogue. Would be one of the first things. And when I say safe spaces, I really mean safe spaces for those that disagree with what we're saying today. They need an opportunity to be able to voice their opinion, their side of things, without feeling like they're going to be attacked or persecuted or what have you. We need to have a forum in which a constructive dialogue can happen. I love what agencies like the People's Institute for Survival and Beyond. Thank you. I love what they're doing, because while the space is not, they create a safe space. It's not always a comfortable space. Okay? Follow what I'm saying. It's not comfortable for everyone that's in the room. So they're doing exactly what you're talking about. But it is a safe space where they allow for varied opinions to be shared and explored. So I think things like that they're doing, those are things that we can emulate within our churches, within our community groups, within our homes and our families, and we can create, because I think it really just starts with each one of us deciding that we're going to do something in our own lives that makes a difference, that, you know, adds to the whole.
And to add to that, I think, and to get to your question, I think there's a need to understand what's important to the individuals that aren't here. Try to find some way to identify what's important to them, and so that when you craft a message of, hey, this is an issue, you craft it in a manner that speaks to what they have prioritized as significance. And I think for many of those individuals whom I think you're talking about, funding is something that is of significance to them. And I think to a larger degree, diversity is true, also something that is significant to them. So I think finding what's a priority to them and wrapping your message in that language so that they feel more comfortable coming to the table and moving forward. But I also think that we to the point that you stated earlier, it is often that it is just going to be preaching to the choir. And though we find that that sometimes feels like it doesn't get us somewhere, the more people we add to the choir, the bigger the noise that we can make. And so people just can't ignore 100,000 people or 1 million people or 25 million people saying the same thing. And so I think these kind of opportunities are significant, but but it's also important to identify what the priority is for that person or that entity, and wrap the message around that.
And I think that's an excellent point. I think Earl makes an excellent point around the idea of money, because that's an all-encompassing thing that all of us can, you know, I'm looking at a lot of people shaking their heads. Yeah, money, yeah, money. So the thing is when we say, and it was mentioned in the presentation, that by doing some of these things, we could really cut healthcare costs because we're being more preventative in some of these things. And so that is probably maybe some language that other folks would be able to get on board with, because we're talking about saving all of us dollars, you know. So yeah, finding those inroads, I think, was an excellent point. Any other questions?
And I think we've seen an example of that with what's happening inside the state, where you have Republicans and Democrats coming together to deal with the criminal justice system. And I think what they have found was it was costing us too much money. And so that to me speaks to the need to identify what is a priority, what is of significance to them, and typically it's going to be money. But thank you guys so much. We have enjoyed it. I will send the references. I'm going to compile them. I'll probably compile them by Monday. And I'll send them to Naomi, and so.
Thank you guys.